Hello everybody and welcome to a tutorial on acute kidney injury. This covers core condition number 2 in the acute medicine curriculum for MBBS Year 4. Okay, so acute kidney injury is a global health issue and it's associated with increased morbidity and mortality, prolonged hospital stays and spiralling costs. The majority of causes of AKI are secondary to sepsis and hypertension and are potentially reversible if the patient recovers. So let's look at the AKI in perspective. So AKI is a cause of up to 5% of all UK hospital admissions. The incidence increases with age. There is a 10% mortality in uncomplicated AKI and up to 80% mortality if renal replacement therapy is required. And those who survive may develop chronic kidney disease. And of course, the development of chronic kidney disease also will increase the risk of cardiovascular disease. Therefore, prevention and prompt treatment of AKI is essential to reduce risk and preserve kidney function. So just as a very brief reminder of basic renal science, the main roles of the kidneys are regulation of water excretion, electrolyte balance, acid-base balance, blood pressure, and also endocrine functions such as secreting EPO or erythropoietin and activating vitamin D. This is just a couple of slides of a reminder of the anatomy of the kidneys. AKI has many causes, some of which will require immediate referral to nephrology, urology or radiology teams. It is therefore essential that the cause of acute kidney injury is identified in all patients, otherwise treatment may be delayed, resulting in the addition of further injury to the original insult. The causes of AKI when it occurs in hospital are similar in both developing and developed countries. However, the causes of AKI in the community differ in developing countries from developed countries. Those causes from the developing countries include preeclampsia, hemolytic uremic syndrome, malaria, leptospirosis or Weil's disease, snake bites and dehydrating illnesses such as dysentery. The majority of cases cause acute tubular necrosis, where that's caused by a prolonged period of renal hypoperfusion and renal ischemia. Acute blunt trauma to the kidneys is relatively rare. The presence of acute tubular necrosis is moderated by vasoconstrictors such as endothelin and reduced presence of dilators such as nitric oxide. The blood flow decreases and the glomerular filtration rate falls. This in turn causes hypoxic injury such as in the proximal tubule and the ascending loop of Henle. The necrosis of the kidney cells releases slough into the lumen, which may then in turn form a block to urinary flow. So this is a pictorial diagram of the different type of cast cells that could be seen in a patient's urine. When we're analysing urinary casts, you want to basically classify those into pre-renal, intrinsic and post-renal, and then you can see the different type of casts that you might see in each type. So in pre-renal failure you may see hyaline casts. If there's an intrinsic cause such as interstitial nephritis or tubular necrosis, you might see muddy brown casts in acute tubular necrosis and urine eosinophils in allergic interstitial nephritis. When you look at glomerulonephritidis, you may see red blood cell casts in nephritic syndrome and fat oval bodies in nephrotic. In those patients who have chronic renal failure, you may see waxy or broad casts. So let's have a look at how we define acute kidney injury. So 1 in 5 emergency admissions are associated with acute kidney injury, and in simple terms it's a rapid fall in the glomerular filtration rate. You may also see oliguria, which is where the patient is passing urine at less than 0.5 mils per kilo per hour. You will also see biochemical markers affected such as serum urea and creatinine. A fairly simple algorithm is known as the rifle criteria. This is where you have patients who are at risk of renal dysfunction, injury to kidney, failure of kidney function, loss of kidney function, which then progresses to end-stage renal failure. And you have here, when you're looking at urine output criteria, you have increased creatinine or GFR decrease of greater than 20% in risk, all the way through to end-stage renal disease. When you look at it in urine output criteria, you have urine output of less than 0.5 mils per kilo per hour over 6 hours, all the way down to end-stage renal disease. Now, new definitions have been developed to reflect the fact that even seemingly minor changes in serum creatinine are associated with a significant increase in risk of mortality. The term acute kidney injury has now replaced the term acute renal failure and is defined by criteria that are dependent upon either rises in serum creatinine level or reductions in urine output. Acute kidney injury should be regarded as a spectrum of injury that may progress to organ failure and the need for renal replacement therapy with associated increased mortality, as I've spoken about earlier. So patients particularly at risk of acute kidney injury are those who are above the age of 75, have pre-existing chronic kidney disease such as an EGFR of less than 60 mils per kilo per 1.73 meter square body surface area, previous episode of AKI, debility, dementia, heart failure, liver disease, diabetes mellitus, hypotension, where there's a mean arterial pressure of less than 65 millimeters of mercury or a systolic pressure of less than 90. Sepsis, hypovolemia, nephrotoxins such as gentamicin, non-steroidal anti-inflammatory drugs, iodinated contrast, and antihypertensives in setting of hypertension such as again ACE inhibitors and also loop diuretics. AKI occurs most commonly in at-risk patients or those who are acutely ill or have had major surgery. Recognition of those at risk of AKI is important because patients may develop AKI whilst in hospital or in the community unless specific preventative actions are taken. And these may be as simple as ensuring that adequate hydration is maintained, especially in vulnerable patients who are unable, for whatever reason, to sustain their own hydration, and we'll come on to that a little later. So here are a couple of resources to point towards for those at risk in primary care. There's a diabetes patients nephropathy guideline on www.diabetes.org.uk/type 2 diabetes. Those with CKD, there's also NICE guidance, www.nice.org.uk. And as I was saying, those who have dementia may have an inability to self-care. They may have even further difficulty of fluid regulation when they're unwell. They may have forgotten that they to drink or eat, for example, or may think that they have eaten and drunk enough. It's also important, of course, to review medications in those who have dementia. AKI in the setting of cardiac failure may be especially difficult to treat. Overall, the aim will be to restore the best possible perfusion to both heart and kidneys. In the setting of obvious fluid overload, diuretic therapy may offload the heart adequately to improve both cardiac output and renal perfusion. In the hypotensive patient, however, with poor cardiac output, therapeutic options may be limited. Some studies have demonstrated temporary benefit from hemofiltration. However, in this situation, senior input is required and a review of the overall patient benefit should be initiated. And this, of course, should also include discussion about appropriate levels of care. Psychiatric patients are also at risk of AKI. They may have a lack of ability or motivation to care for themselves. They may have laxative or diuretic abuse, such as those seen in anorexia. The administration of lithium can cause AKI. You may see AKI secondary to the side effects of recreational drug use, such as ketamine-induced ulcerative cystitis, synthetic cannabinoids, and legal highs. You may, of course, have self-harm to the kidneys via poisoning through overdose or the use of antifreeze. And, for example, there are instances of paracetamol-induced AKI as well as hepatotoxicity. Another website to point you towards is www.thinkkidneys.nhs.uk. So when you're looking at the different causes of acute renal failure, you can essentially classify them into three ways: pre-renal, intrinsic, and post-renal. Pre-renal AKI is often due to sepsis, hypovolemia, such as may be seen in hemorrhage, burns, vomiting, diarrhea and diuretics. Also, decreased effective circulating volume, such as in hepatorenal syndrome and cardiac failure, and in hypotension, such as medications. Intrinsic renal failure may be classified as acute tubular injury, as I've already spoken about earlier, such as prolonged pre-renal AKI, rhabdomyolysis, hemoglobinuria, nephrotoxins such as iodinated contrast, nonsteroidals and gentamicin, tubulostichial injury, myeloma, glomerulonephritis and vasculitis such as lupus and ANCA-associated autoantibodies. And finally, post-renal, such as kidney stones, prostatic hypertrophy, tumours and retroperitoneal fibrosis. Patients with most forms of AKI lack specific symptoms and signs early in the course of the injury, and detection requires a high index of suspicion of those at risk. The NC-POD report demonstrated that the diagnosis of AKI was delayed in 43% of patients. For example, hospitals have now introduced AKI warning systems via electronic alerts and so on. In March 2015, all NHS trusts in England mandated that biochemistry department laboratory information systems must issue an AKI warning based on rises in serum creatinine level for all patients in secondary care with AKI. Some NHS trusts have chosen to develop AKI care bundles, which we will talk about a little later. Patients themselves, especially in those high-risk groups, should be made aware of the possibility of AKI developing in certain situations. Those include when dehydration becomes a real possibility, as is likely to occur with diarrheal and vomiting illnesses. Temporary cessation of drugs that may exacerbate hypovolemia and or hypotension, such as diuretics, should be encouraged. However, it is critical that the need for these medications is reviewed, and we'll come on to this in a little later. It's important to maintain a high index of suspicion in patients without an obvious precipitating event for the rarer forms of AKI, such as vasculitis and tubulointerstitial nephritis, which may occur in association with systemic symptoms such as rash, fever, lethargy and joint pain. You may also see things like cardiac arrhythmias, such as those who have an elevated potassium. So investigations of AKI, initial investigations will include urea and electrolytes and creatinine levels, bicarbonate, full blood count, and if the platelets are low, consider requesting blood film and lactate dehydrogenase to diagnose a hemolytic uremic syndrome or thrombotic thrombocytopenic purpura or TTP. Liver function test to diagnose hepatorenal syndrome, calcium and phosphate to diagnose myeloma, creatinine kinase to diagnose rhabdomyolysis, blood cultures if sepsis is indicated, urinalysis if blood, protein, leukocyte or nitrates send midstream urine, and an ultrasound tract of the renal tract and bladder. If obstruction is suspected, scan within 24 hours, and if pyonephrosis is suspected, you should scan within less than 6 hours. You may also take a biopsy, do a blood gas to look for metabolic acidosis. You may also organise a chest x-ray to look for signs of pulmonary overload and cardiomegaly, ECG for evidence of hyperkalaemia, CRP for evidence of associated infection, and a vasculitis screen, which would include immunoglobulins, electrophoresis, autoantibodies, which are ANA, ANCA, anti-double-stranded DNA, and anti-glomerular basement membrane in those with AKI. Just as a reminder of the ECG changes that are seen associated with hyperkalaemia, you will often see PR interval prolongation first, followed by tinted T waves. You may then lose the P wave and get ST segment change and prolonged QRS or broad complexes on an ECG. Then you may finally see a cine wave QRS complex before the patient goes into cardiac arrest. So in summary, you'll see tall tinted T waves, small or absent P waves, widened QRS, cine wave pattern and asystole as the hyperkalaemia progresses on the ECG. So how to compare AKI versus CKD? Well, the first thing to do is have have awareness of previous biochemical results, which will make the differentiation quite simple. Pre-existing CKD is a risk factor for AKI, and deteriorating biochemistry against a background of known abnormal renal function clinches the diagnosis. When a previous blood test results are not available, the clinical presentation may well indicate AKI such as hypovolemia and sepsis. But it's also important to look for other biochemical features such as a coexistent anemia, hyperphosphatemia and hypocalcemia, which would suggest CKD. An ultrasound scan showing small kidneys suggests CKD, whereas normal-sized echo bright kidneys are more suggestive of a form of AKI. So the management of AKI is supportive therapy with close monitoring. You want to focus on treating sepsis aggressively if present, reducing restoring hemodynamic stability, avoiding nephrotoxins and preventing iatrogenic harm to the patient, and identifying the underlying cause. Further treatment and pathways of assessment is shown on here. You may also need to organise further treatment to manage the complications of AKI and to relieve any renal tract obstruction if present. So this is a simple acronym about the initial management bundle. So you want to assess the patient, fluid therapy, treat any hyperkalemia, urine dipstick, review the medication, repeat the creatinine the next day, renal tract ultrasound within 24 hours, and strict fluid balance charts. There is, if you want to have a look further, details on www.londonaki.net. This is another form of AKI management. So you've got A, B, C, D, E, IT, and that basically looks at acute complications such as high potassium acidosis and fluid overload. BP check to restore normoperfusion. Catheterize and measuring fluid balance. Drugs, stop and avoiding nephrotoxins, excluding obstruction. Investigations, including urine dip and renal screen, and of course to treat the cause. So indications for dialysis include severe uremia, which would present as encephalopathy, vomiting and a urea of greater than 60. Persistent hyperkalemia, which is greater than 7 millimoles, persistent ECG changes or greater than 6.5 millimoles per litre and unresponsive to treatment. Severe metabolic acidosis, such as a pH less than 7.2 and a base excess of less than 10. Uremic pericarditis and refractory pulmonary edema. Just to talk about on the final slide about complications of AKI and how to manage those. There are tutorials on IV fluid therapy on the Acute Medicine Moodle, and also how to prescribe IV fluids and fluid resuscitate. Complications of AKI, I've put the algorithm up on Moodle for you, but in brief, mild hyperkalemia, you'd want to consider the cause and treatment if indicated. Hyperkalemia, or which is moderate, between 6 and 6.4 millimoles per litre, will be guided by the clinical scenario and ECG, but you may consider 50 mils or 25 grams of 50% glucose, or 125 mils of 120% glucose with 10 units of soluble insulin. That effect lasts for 4 to 6 hours, and you'd want to measure the glucose accordingly. You could also give salbutamol nebulizers up to 10 to 20 milligrams, although 10 milligrams if there's a history of ischemic heart disease. You want to avoid salbutamol, of course, if there's a tachyarrhythmia. Severe hyperkalemia is managed with 6.8 millimoles of IV calcium, which is either in the form of 10 mils of 10% calcium chloride or 30 mils of 10% calcium gluconate in a large vein, and you'd want to make sure your patient's in a monitored bed. If there's severe acidosis, you could consider IV sodium bicarbonate, although you'd want to discuss this with a senior doctor. Pulmonary edema, you want to sit the patient up, give oxygen 15 litres, IV glycerol trinitrate, and furosemide only if the patient is hemodynamically stable and well filled intravascularly. Should the patient develop renal replacement develop uremic encephalopathy or pericarditis, then renal dialysis may be indicated. Patients recovering from a significant episode of AKI might develop profound diuresis resulting in a free water deficit. hypernatremia and or hypokalaemia. During this phase, maintaining patient hydration and replacing electrolytes are of paramount importance. This may require fluid replacement in very large volumes. Accurate fluid balance with daily weights is very important to prevent patients from becoming dehydrated as they recover from AKI. Patients who have had an episode of AKI are at risk of CKD in the long term. This risk depends on the severity of the episode of AKI. Patients' kidney function should be checked prior to discharge. Refer patients to nephrology if they are discharged with an estimated GFR of less than 30 mL per minute. Medication should be reviewed prior to discharge with a plan to reintroduce medications that may have been held during an acute illness. You might want to arrange early follow-up with a GP. Patients should be told the reason that they developed AKI and the risk factors, and it is recommended that the GP discharge letter should include severity of AKI, cause of AKI, risk factors for AKI, kidney function on discharge, and advice on what medication should be reviewed or reintroduced. Okay everybody, I hope that was a useful tutorial. Feel free of course to use Acute Medicine Moodle for any discussions or questions that you may want to start. Take care everybody, bye bye.